Our final talk in this session before morning tea is from Gary Grohmann. Gary's going to talk to us about vaccines in the pipeline and on the drawing board. Gary, thank you.
Okay, back to the fabulous world of vaccines, already started by Terry there. So I hope this is a good adjunct to his talk actually as well. So firstly, just wanted to thank I presume you pressed the green button, is that? Okay. I just wanted to thank the organisers for the invitation to speak. Today, I really just want to provide a snapshot of some of the COVID vaccines in the pipeline and a few on the drawing board, concentrating on current manufacturers. Of course, like Terry, it's not possible to cover everyone. There's such an extraordinary explosion of vaccines all over the world. In terms of declarations, the slide's gone, but in terms of declarations, I'm on a number of committees or advisory groups involved with CSL, Securus and BioIntellect. And I'd like to thank all these people that I approached for various bits of information. Chris Clark from Moderna, Alberto Stella from GSK, Julie Bayliss and her colleagues from CSL Securus, also Darren Gilchrist from Novavax, David Muller from Vaxus, Tim Hurst from GPN Vaccines, and also thank Jenny Hertz from BioIntellect and Chris Kyriakis from BioSelect for information and advice. And Robert Boy and Manon Cox are mentioned there as well. They're on the boards of those companies and good friends and also provided useful information. And also the IVR SAGE group at WHO, and I think we'll begin with that. At WHO, as of January 23, they've identified 176 vaccines that are in clinical development and 199 in preclinical development. So 56% of those comprise of 2 doses and 82% of the vaccines are administered by intramuscular injection. So that I think is an interesting snapshot by itself. Go on further to describe some of the platforms. And you can see that the protein subunit and RNA vaccines are the most popular, 33%, 23% respectively. So most of the candidates have actually moved on to phase 3 and then registration. If you looked at this slide 6 months ago, you would have seen many in phase 1 and 2. So it's kind of interesting that over 90% of those have moved on to phase 3, and then one could expect the same percentage then to move on to registration. So there really is an explosion in vaccines that will be available. There'll probably be somewhere between 40 and 45 vaccines available in the next year or two, according to WHO. It's also good to see over 50 in the preclinical as well in phase 1. So we have vaccines in development. Recent ones we know about, combined influenza and COVID vaccines. We know that Novavax is currently in a phase 1/2 combined COVID influenza study. And the data suggests that this combination is quite feasible, well tolerated, immunogenic. Moderna's in a phase 1 for a combined vaccine. It also has its RSV vaccine combined 3 ways. And then we have new vaccines that are actually registered or in phase 3. These include Moderna's variant-specific vaccines targeting Beta, Delta, and Omicron, the Pfizer vaccine with Alpha and Delta, and Novavax also has a phase 3 program targeting subvariants, so monovalent and bivalent vaccines in adults. So many groups are looking at second-generation vaccines, and we'll begin with CSL's Securus. So these second-generation vaccines generally use self-amplifying messenger RNA in some form. And there are 2 key elements that drive this, as we know. There's the messenger RNA itself, which can be either have several genes or just 1 gene, and of course the all-important lipid nanoparticle to deliver it. They have collaborated with Arcturus, who have their star and lunar system of delivery, and I guess we'll hear more about that later. But this appears to be incredibly promising according to some of the data. They have a pivotal study at the moment involving phases, and they've gone through now to a prime boost strategy. The phase 3 study shows 95% efficacy. This is in 16,000 subjects. Overall for prevention of severe COVID, and 55% efficacy overall for prevention of symptomatic disease, which is very encouraging. If we look at Pfizer, you can see they have quite a lot of vaccines that are already registered, and some of these we'll know. But they also have a number of others in phase 1, 2, 3. And we can see there down the bottom, they've got a combination COVID and influenza vaccine as well. So another one that's in the pipeline. If we look at Moderna's respiratory vaccine pipeline, they're targeting all age groups and also a number of combination vaccines. So we're familiar with the ones that are registered for adults, adolescents and pediatric. And down the bottom again, they have a COVID plus flu and a triple vaccine, COVID plus flu plus RSV, all messenger RNA. So the messenger RNAs that they're using are here on this slide. We'll see the COVID plus flu vaccine, and I think we've yet to see the data on this. And of course, the triple one, the COVID flu and RSV, giving hopefully an adult pan respiratory vaccine candidate. So these are some of the combination strategies that are being involved here. They also have a bivalent vaccine clinical program looking at the ancestral strain plus beta or plus Omicron BA1 or plus Omicron BA4-5. And again, they tick all the boxes in terms of safety, efficacy, tolerability, and so on. And some of these, of course, are registered or about to be registered. And they have a next generation COVID-19 vaccine, 1283. But the reason for this is to have improved refrigerator stability, which is all important for mRNA. And they're in a phase 1-2 study at the moment. So GSK also have a self-amplifying messenger RNA vaccine. It's really just off the drawing board and into phase 1 clinical trials, and it's highlighted there. But they also play a very significant supporting role with other companies. You can see that with Sanofi, Medicago, down the bottom, SK Biologicals, they provide adjuvants. With CureVac, they're supplying support in manufacturing, and for Novavax as well, they're providing support in manufacturing. Novavax, as we know, is this nanoparticle vaccine, and this is the process they use to eventually produce proteins that form into nanoparticles. And in their pipeline, they have the vaccine that's already registered, a number of others there, including combination COVID and influenza, and down the bottom, combination influenza and RSV, and influenza COVID and RSV as well. So again, more in the pipeline there for them. But this explosion of novel vaccines is not limited to mRNA. And I want to talk a little bit about the inactivation of viruses using gamma irradiation technology by GPN vaccines, which is rather novel. This really is on the drawing board at this stage when it comes to flu and COVID. But they've been using gamma irradiation on flu in particular, and technology has obviously improved in this area. Years ago, there were papers on UV irradiation trying to do a similar thing. So the idea here is that UV, and in this case, gamma irradiation, would affect the nucleic acid but leave the surface proteins intact. The advantage, of course, is that no chemicals are used. So therefore, having the surface proteins intact will give a better immune response in theory, and of course, less allergic reaction, presumably as well, if no chemicals are involved. So this is very much on the drawing board, but I think quite exciting. And the proof of concept has really come through the pneumococcal vaccine, which I'll talk about in a minute. But looking at some of their preclinical data first, you can see here that the gamma irradiated flu affords 100% protection against heterotypic challenge. And that, I think, is a very important slide. And you see that in box D there, where there's 100% protection. And the next slide, there's something similar, where the gamma-irradiated virus for an H1N1 affording 100% protection against a homotypic challenge. So these are important preclinical data, which give a lot of confidence, I think, firstly in the platform and the process. And it will be interesting to see how this goes once it comes off the drawing board. But the pneumococcal vaccine is definitely off the drawing board and very much in the pipeline. It's a platform, and I think there'll be an announcement about it this year. This vaccine's been incredibly successful. It's a whole cell vaccine, so it has all the serotypes there. It's highly immunogenic, producing strong IgG responses. I'll show that in a moment. Produce an immune response to both Prevnar 13 and non-included serotypes. It affords long protection against experimental pneumococcal infection. Seems to be more effective without an adjuvant, safe in animals, even prior to irradiation, and easy to manufacture. So in terms of the antibodies produced, it's capable of binding to the pneumococcal surface, despite the presence of polysaccharide capsule. It's capable of recognizing the protein antigens to all the serotypes, not just a few. It's functional, as demonstrated by the phagocytic killing of encapsulated pneumococci. Now, as I said, there'll be an announcement about this, and I think it's rather exciting because from the point of view of virologists, at least, it shows incredible confidence in the platform itself. And it'll be very interesting to see not only the data on this as it's announced and see it proceed, which I think will be almost a certainty from phase 3 into registration. I think this has big implications for viruses as well, if it can be applied. The manufacturing part of it is quite simple, if any manufacturing is simple. But here they have, for the pneumococcal, their GPN strain, then they have an inoculum and fermenter and so on, then downstream processing, filtration, and then vialing and storage, and then they gamma irradiate. And then there's a final drug product. So much simpler than you might expect. And if this can be transferred to viral culture for influenza, say, then I think it could be potentially a game changer. Certainly, I think it should be part of future planning. Future pandemic planning should include these kinds of ideas. The Vaxus has already been spoken about, so I'm not going to dwell on it particularly, except I wish someone would start using it. It'd be good to see it in arms and see what's going on. So it'd be nice to see good phase 3 data on flu and other viruses and other antigens. So we're still using this 170-year-old system, and I won't dwell on this too much as it was already covered by Paul. But just to point out that the materials have changed in the last few years. It did take about a decade to get the materials right and the engineering right in terms of coating the spikes and so on. But now we have not only solid maps, but dissolving maps and also the hollow ones as well, and they're easily applied by a hand applicator. But this is good data, I think, on the maps, the largest clinical validation study. And it shows not only superior immune responses on the left, but very importantly, dose sparing. So 6 times dose sparing on the graph on the right. And, you know, that really shows how important this kind of technology could be, not only for current vaccines, but also future pandemic vaccines. And again, like the GPN should be part of our thinking for pandemic planning. We really need to see this kind of technology being used. And also the antigens are stable on these types of patches, so they're easily moved around. Unfortunately, it's still a bit of a wait and see, but been on the drawing board and the pipeline for a long time, and it would be good to see it starting to be used. Some information here, an estimate, if we had have started using maps at the start of the pandemic, there would have been 16 million fewer cases and 200,000 fewer deaths. So vaccine side effects, and I'll finish with this. Well, we don't see too many. I've been following the TGA reports, and this is the latest one. So only 2.1 per 1,000 doses are being reported of any sort of side effect. Most of those are attributed to the AstraZeneca and Pfizer vaccine, but that's not surprising, simply a numbers game, as the Spikevax and the Novavax vaccine haven't been used as much. But didn't particularly go into further detail, but that 2.1 is much lower than I expected. And I think goes to show that these vaccines are fairly safe. But there are, of course, a few rare serious side effects that we do know about. Again, from TGA, there's myocarditis that we know about, and TTS. No need to go over that. 14 deaths have been related to vaccination, unfortunately. 13 to the AstraZeneca and 1 to Spikevax by the TGA, that is. I did have a look at the FDA CBER data. They also provide snapshots of side effects, and they've been particularly following mRNA vaccines. So a snapshot from 42,000 reports shows 2.5% do get cardiac issues, myocarditis, pericarditis, heart arrhythmias, essentially. So quite a wide variety of them, but they do seem to all resolve. Many more than I expected have GI issues, 24%. And 17% have fatigue. Now, these are much higher numbers than what I see elsewhere, but it's interesting to follow the US data as well. European data shows something similar, but not as high. So just a few final comments. It's pretty clear the second generation vaccines are needed. And although we may all think it might not be possible to stop transmission, that's the vaccine we need if we're going to sell it to the public. We must have improved safety profiles as well. Even though we think these things are tolerable and resolve and so on, in general, the public don't like it. And I think we have to start listening to people in the pub, so to speak, as to how they feel about some of the safety issues when they get their vaccines, and they might have to take a day off work, or they feel particularly unwell or compromised in some way. Adjuvants also need better safety studies, and there are more and more adjuvants coming along. Generally, regulators really don't like adjuvants, so it's interesting to see more of them get on the market, particularly through the FDA. So COVID vaccines must gain acceptance. Combination COVID and flu rather than concomitant vaccines seems to make a lot of sense. Probably annual vaccination and maybe biannual for those that are at higher risk would also seem to make sense. And I think that will be very easily sold to the public. mRNA, self-amplifying RNA recombinant protein vaccines are clearly the most successful. Nanoparticles studded with COVID proteins, and work's been done by Caltech, also looks to be very promising as well. So once you get one of these platforms and able to add either more genes or more proteins to the matrix, then I think they're the kinds of vaccines that might eventually get us to the point where transmission can be halted in a more meaningful way. There has been some work done on intranasal and oral vaccines, and there's no doubt they have a faster immune response than intramuscular vaccines, but they haven't been that successful yet. But it's an area that plenty of people are pursuing. The gamma irradiated vaccines, the use of MAPS, I think hold a lot of promise for the future and should start coming to our thinking. And I look forward to the pneumococcal data, which I think will be a good proof of concept for these types of vaccines. Thank you.
Great talk, Gary, and a nice compliment to Terry and Alan's talk beforehand. You're saying we need to stop transmission, but it's interesting, only 3 of the 176 vaccines in the pipeline are looking at any sort of mucosal transmission. So 2 parts of the question: do we understand the biology enough? Because my understanding is the mucosal vaccines have not been effective to date. And why doesn't there seem to be more interest in that if we want to be serious about stopping transmission?
Well, it seems to have become a holy grail and slipped down in our thinking. We've put the emphasis on and rightly, on the prevention of death and severe disease, hospitalization, and so on. They're achievable endpoints, but we need now to go beyond the spike, so to speak. We need to go beyond immunogenicity. We need to understand the whole T-cell response a lot more, and we don't know why the current vaccines are not protecting against transmission. Even if we get 50%, we'll be doing well. You know, we're not going to beat this pandemic with current vaccines, no question, never. we'll just be in a situation where we'll have to continue to vaccinate. We won't beat the virus. So we need to change our thinking a bit. Maybe we need protein and mRNA vaccines given concomitantly. Maybe we need an oral and an IM being given together. We just need to thinking beyond what we're doing. And what's happening is, of course, wonderful. mRNA has changed the landscape big time. But we need to keep going with it, I think, in my view. We can't just sort of stop and say, well, we've saved the hospital system and the death rate in people over 70 has dropped and everything's okay for healthy people and so on. But we need to keep going, I think, and have that as an aim. Let's stop transmission, even though some of us in the room undoubtedly will think that's not possible. And it isn't at this stage, but we have to keep aiming for that, in my view, and understand a lot more about the immune response as to why it's not happening. It's happening with measles and hepatitis A and lots of other vaccines, but not this one.
Gary, Rod, there's a question.
Gary, do you think the pub test or the water cooler test is helped more by having a more effective vaccine, a safer vaccine, or different technology that doesn't scare the mRNA? Like, is it so entrenched in social media that really we've lost this battle and we've got to invent something else? Or do you think if it was just safer and no transmission, what's your bet on reducing the antibodies at the pub?
Well, people live in fear, whether they're politicians or people with kids, people in the community, they really do live in fear. They don't know what's going on. They rely on GPs in particular to tell them what's going on. They're the people they really trust, and we know that. They don't particularly trust the politicians or vaccine manufacturers or any of us in the room that are researchers or involved as consultants, whatever it may be. They certainly trust the GP network, and that's really important to know. I think there's a lot of evidence for that. So my take on it is that safety is always number one. But they want to also have a vaccine that they don't have to get all the time. Adults and children don't want to get a vaccine constantly. Yes, you get your hepatitis B, you get your hepatitis A or measles, mumps, rubella, whatever it is, but you're not getting it every year. Flu is a different case, and we can argue for that one, arguing for COVID as well, and arguing for another one as well. If it's another mRNA vaccine, let's say RSV, we need to get all the time as well. It's going to be a much harder sell. Safety is certainly important, but also this frequency of getting a vaccine. People get tired of it and they just won't want to do it. As we have seen, we're trying to sell a third dose or a fourth dose, let alone a fifth. It'll be very difficult. For people that are really unwell, it's a much easier sell. It's the well community that's difficult for, not people that are immunocompromised who have underlying disease. They will certainly take it all, well, almost certainly. Let's say about 90% of them.
Well, except Gary, as Alan suggested, there have been more deaths in that compromised elderly group in the last 12 months than there have been in the previous couple of years. Is that just time catching up, or are we using the wrong approach?
Oh, well, I think, the virus has changed for a start. So potentially there's some immune escape. I think it is time catching up. The epidemiologists in the room can crunch the numbers and work out if it's significant or not. But I think it's just time that's catching up.
Again, as Alan suggested, it's not a pneumonitis. It's a sort of just a generalised debilitation, and they literally just fade away in hospital.
Yeah.
Any thoughts about how to stop that? Or is COVID the new old person's friend, like influenza used to be?
I don't know, we used to call it the boomer remover, right? Have you heard that phrase? I heard that phrase at some conference. I thought it was terrific, but not very good if you're over 70. Maybe. I mean, I just don't know.
Well, it's a pretty depressing note to finish.
It's a depressing note to finish on.
Except Ian
has a question.
Ian might be able to
lighten the mood.
Cheer us up before morning tea.
Gary, I'm a bit surprised by your enthusiasm for the GPN influenza vaccine, given it's presumably a whole virion vaccine, and we know whole virion vaccines are quite reactogenic. So why would gamma radiation change that landscape?
It's going to be a step-by-step thing. Having a whole virus vaccine for flu isn't a bad thing, particularly for adults and older adults. There might be a real application there. There may not be an immediate application in children. Regulators will almost certainly want it split. And that will sort of go against their philosophy, I guess, because their philosophy is let's not add chemicals, let's just gamma irradiate. So that'll be an interesting point, but they'll have to go step by step and undoubtedly, well, I'm not sure really, but I would expect that they would produce, say, a flu vaccine and try it in an adult population first, look at the safety from that, and then move on. It'll have to be the usual step-by-step process. It will definitely take time. Yes, it is on the drawing board. I hope it does get into the pipeline eventually. I think it's potentially a game changer myself. But there'll have to be a different approach for children for sure, and that'll be a regulatory demand.
Gary, thank you.
Thank you.
Terrific talk. This ends the first session. It's time for morning tea. Please move your legs. The number of steps you use every day adds to your longevity. We'll see you back at 11 o'clock. Thank you.